Next, we're joined by Professor Michel Michaelides, Professor of Ophthalmology at University College London and Consultant Ophthalmic Surgeon at Moorfields Eye Hospital. In his session, he'll be giving us an overview of what's been achieved by researchers in previous years. We'll not have time to take questions during this session, but Michel will be joining us during the Meet the Speaker session this afternoon. We will be able to ask your questions then. For online delegates, you can ask your research-specific questions to Professor Julie Silvestri. Please welcome Professor Michel Michaelides to the stage.
Thank you. It's very kind. It's going to be tough to follow John and a cake, but I'll do my best. In theory, this should be 25 minutes, but I'll try and keep it shorter to give Jane some time before we run out. So my title was The Journey So Far, Genes, Machines, Misses and Marvels. It's a real pleasure to be here for 50 years. I'm of a similar vintage. I think 50 is a great number. I think we've gained a lot of experience, and I feel we're ready to exploit that experience and go on to better things. So as has just been said, I'm going to give a little taster of some of the research that has occurred, particularly over the last 10 to 20 years. Retina UK, originally BRPS, then RP Fighting Blindness, has really played a very major role throughout, both in terms of funding multiple different research projects and endeavours, and also equally importantly in terms of advocacy. I'm just going to be indulgent for a moment because I'm in my 50s, so I'm going to mention my personal retina journey. I actually started training in ophthalmology, or eyes, in Basingstoke, and actually the reason I'm here is because my mentor in Basingstoke, Simon Keatley, invited me, and I remembered that at the time, it was very exciting to start my journey in ophthalmology, but thinking that because I couldn't find the retina on the microscope, so remember we examine patients on a microscope, many of you will have been on that device, seeing the front of the eye is really very straightforward. Finding the back of the eye, the retina, while we're all here today, is a little bit more challenging. And I found it so challenging, I was generally concerned I wasn't going to be able to become an eye doctor. My first research publication was almost 25 years ago on eclipse retinopathy, so the hazards of looking at an eclipse without appropriate protection or measures put in place. And it's actually John Marshall was a co-author on my first publication ever, and you're always very proud of your first publication ever. And I was in my first year of junior ophthalmology training at that time. I decided at the end of my junior training, which usually about 3 years, you do all your exams, ready to then apply for senior training, that I wanted to take a period of time out to do some dedicated research. I wasn't very well connected, hadn't realized many of my colleagues were already speaking to people like John and others to try and get jobs in their labs and do a research degree. So I just applied to an advert in the BMJ at the time, and it was to work on cone and cone rod dystrophies. I think they're one of the listed over there. I didn't have a clue what cone and cone rod dystrophies were, but it sounded interesting. And it was to work at UCL and Moorfields, where I currently am now, and it was to work with Tony Moore as my primary supervisor. Didn't know who Tony Moore was. I subsequently realised that he was one of the titans of inherited retinal disease. He and Alan Bird are really the foremost authorities in this area. And it was to do clinical investigation, so to see patients and do detailed testing on their condition, to learn more about their condition, and also do some genetic testing in the laboratory. It was a great 2 years. I learned lots in the lab. People often refer to it as basic research. There's nothing basic about laboratory research. It's fundamental, but it really isn't basic. And meeting loads of patients was, incredibly rewarding. That's where I first met Alison Hardcastle and Mike Cheetham, who are very much involved in Retina UK, and started the journey of using different devices, assessment tools, to try and get a deeper understanding of disease and how it changes over time. And I worked with people such as Fred Fitzke, Andrew Stockman, and John Mollen in Cambridge. And it was after that research degree that my destiny had been set. I was passionate about inherited retinal disease. I carried on research throughout my senior training and primarily focused on working with groups looking to identify the genes causing inherited retinal disease, including RP LCA, cone, rod dystrophies, and all the rest that are listed there. But more so to work with patients to try and better understand their conditions and move away from what John referred to of sort of lumping everyone all together in a proverbial dustbin. I'm not sure I like the word dustbin, but yeah, in a bucket. I don't like that either. But lumping all the conditions together when actually there are hundreds of different conditions. In addition, at that time, I worked with Tony Moore to completely overhaul the website of BRPS, both the sort of about RP, the clinical bit, as well as the research bit. And as has been alluded to, the number of hits that website runs in the millions. I know it's had another iteration recently. So it's an amazing source of information globally, and we should be very, very proud of that. I then spent 2 years in retinal training at Moorfields. And then if that wasn't enough, I spent a 3rd year in inherited retinal training at Casey Eye Institute in Portland, Oregon, working with another titan, Richard Welleber. And there I learned so much from him about seeing patients who had non-eye issues as well, had what we call syndromic conditions, and also ways to better assess the function of the retina using a whole range of different devices. I also met 2 of my closest overseas collaborators during that time, Alf Dubra and Joe Carroll, who are really world leaders in high-resolution retinal imaging, the ability to actually see single cells in the retina. And that allowed us to set up a similar device at UCL Moorfields. In addition, I learned about the possibility of handheld OCT. So OCT, which we'll touch upon when I get to machines briefly, is all of you, or many of you, will have been on these devices, probably all of you if you've been to your opticians, because they're now in opticians, and it allows the ability to look at the retina, the light-sensitive layer at the back of the eye in cross-section, to actually see all the layers of the retina. But at that time, when I was out in this fellowship, it was the beginning of people being able to have a probe, a handheld probe. Rather than having to pop your chin on a chin rest, you could have a probe to use, a little bit like an ultrasound probe that one might use. And that allowed the possibility of imaging patients who had very florid eye movements, wobbly eyes, nystagmus, but moreover children. And the children bit will become very clear why that's relevant when we finish with a condition called AIPL1. I was finally appointed as a consultant in 2010 at Moorfields and UCL, joining the Retina and Genetics Services. Genetics was run by Tony Moore, who I've alluded to, and the other great chap in IRD, who I've still got the pleasure of working with, is Andrew Webster. Again, many of you may know him and may well be seen in his clinics. And then the genetic department, where I worked with Alison and Mike, have I spoken to, and also mentioned, and also Robin Alley, who's been alluded to as a true great in molecular genetics and translational therapies, developing therapies, and Jim Bainbridge. And Robin and Jim described me as their missing link. I hope that was sort of a missing bit of a puzzle rather than sort of an evolutionary kind of sense. But anyway, enough about me. Let's go to the first bit of it, which was genes. So genes and genetic clinical trial development. We've already heard quite a bit from John about the journey to identify the underlying genetic basis, the cause of this large range of genes. And the first gene that was actually identified was rhodopsin, and that was in 1989. And that's the commonest cause of dominantly inherited RP. We'll go into details. I know we're going to meet later, and there'll be loads of questions. And now there are more than 300 genes that cause just retinal dystrophy. It's the most genetically variable condition of anything that affects human beings. It was, to begin with, painstakingly slow, very costly. I remember during my research degree spending entire weekends trying to interrogate a single part of a single gene. And now we can sequence, read the entire human code incredibly rapidly and cheaply. And that's resulted in about 70% of patients being able to receive a genetic diagnosis currently with state-of-the-art testing, which is available freely through the NHS. And we're very, very lucky to have that. We're so ahead of the entire planet with that sort of access to genetic testing. But that does leave 30% of patients who don't have a genetic diagnosis, or we can't find the genetic diagnosis. It definitely is genetic. And one of the, to my mind, wonderful contributions of Retina UK was setting up a consortium, which at that time was called RP Fighting Blindness Consortium. Remember, that was the middle name of the organisation. And what I think was particularly ahead of the time for Retina UK was that they encouraged, more enforced that all groups in the UK that were working to identify genes and to find the genetic basis of disease in patients in the UK had to work together. They had to pool their resources and expertise, use that resource more effectively, and the hope would be that that would accelerate gene identification and finding the genetic diagnosis. And that was absolutely correct. It was very, very fruitful. Those collaborations continue to the present day, and there are other networks, European and international, that have really followed that same blueprint. So I think that was a key thing that Retina UK delivered for the community. Finding the gene helps us to better understand the underlying disease mechanism. It allows better informed genetic counseling, family planning, the ability to try and give a more accurate prognosis to patients, and also to help develop genetic therapies. Allied to that, there's been a tremendous improvement in our understanding of how those specific genetic faults result in changes at within the retina itself. So how the tissue starts to stop to work and then degenerate, or how the cells start to become dysfunctional. And that growth in understanding of the genetics and the underlying mechanism, and allied to different tools that we now have, as John has alluded to, inactivated viruses to deliver genes to the retina, or other tools that allow us to edit or correct parts of the genetic material, have resulted in a whole host of different studies. And that takes us to what I think is another really important achievement of Retina UK, is where they established the Gene Team project, which was at Moorfields and UCL, something that I benefited from as well, being part of that team with Robin Alley and Jim Bainbridge. It was very novel with it conceptually, in that it wasn't to fund a specific standalone, very focused project. It was more to support an entire pipeline, to help our endeavours that had been going for decades prior to get the work that was being done in the laboratory into clinical trial. It allowed a more sustained pipeline to keep the same team and fill in gaps that often are really hard to get funders to fill. And that really resulted in multiple natural history studies and trials, more than any other unit has ever done on the planet. In terms of natural history studies, I'll just list out some genes, and people might recognize the genes. CNGA3, CNGB3, which cause achromatopsia. RP65 causes LCA. RPGR, the commonest cause of X-linked RP. AIPL1, one of the rarest causes of LCA, and we're going to get back to that one. ABCA4, Stargardt, one of the commonest genes causing inherited retinal disease, and RDH12. And then the majority of those actually went on from those natural history studies, where we learnt more about the diseases, more about what measurements are reliable, repeatable, meaningful, to then apply to trials. And for many of those conditions, we went on to conduct clinical trials. Let's touch upon machines next. So you've already mentioned OCT, the ability to look at the retina in cross-section in great detail, look at the different layers of the retina. And adaptive optics is the technology I alluded to that we've brought over here in collaboration with Alf Dubra, that allows us to actually see the specific cones and rods in the human retina, in the living retina. Truly unrivaled. There is no other specialty in medicine that can visualize whatever they're interested in at the cellular level in the living human being. And that's given us unparalleled understandings in the anatomy, architecture, structure, both in terms of identifying appropriate patients and monitoring change over time. But allied to that anatomy, we've got far better ways than we ever had to measure the function. How is the retina working in very discrete local areas that we can keep testing over time? So to have a good readout of whether our therapies are working and whether they're safe. And so those developments in genetics, in imaging, in the functional assessments have resulted in a gigantic increase in clinical trials and therapy development, which takes me very briefly to misses. So something negative, I'm afraid. There's always something negative. So despite Luxturna, which John alluded to as the gene therapy treatment for RP65, that was approved in the UK in 2019. Many of us might have predicted, anticipated, expected that there would have been more approved therapies at this point. And there haven't been. I believe there will be, and I do believe that some are coming very shortly in the space of a year to two. However, my broader retina experience, which I bored you with to begin with, outside of inherited retinal disease, tells me that I've seen hundreds of trials in general retina that don't work. So it's somewhat unrealistic for us to expect that all trials will work. It's always disappointing. I want all trials to work, but I think there are opportunities for us to learn how to do things better and increase our likelihood of success subsequently. There are always many reasons why things don't work. Some can be that the trial wasn't designed appropriately, there weren't enough patients, it wasn't the optimal disease characteristics, conditions that were chosen that would give us the best chance of determining whether it worked. Maybe the wrong assessments were done at the wrong times, or the analysis wasn't appropriate, or the regulators weren't particularly helpful. But sometimes the therapies just aren't effective enough. They're not effective enough. If they were amazingly effective, many of these things would be overcome. But we can learn from that, and we are doing things better, which takes me to marvels. I'm nearly done, Jane. Takes me to marvels. So the first marvel has already been talked about in terms of patient support. I think we shouldn't underestimate the patient support, emotional, psychological, information that's provided online increasingly. It's of great value, partly because, as John's alluded to, there's a lot of nonsense out there. Still, there's a lot of nonsense out there, unfortunately. There's still a lot of clinics around the world, including European countries, that provide therapies, so-called therapies in inverted commas, that are not therapies. They're basically fraudulent and are stealing people's money. But more importantly than the money is that it's false hope, but even more than that, there are some of these therapies are actually harmful. So when I speak to patients, it's just that we don't know if they're safe, and I am actually genuinely concerned some of them could do you some harm. And some of them are particularly repugnant, but we can talk about that separately because they're particularly unpleasant. The other area is advocacy, which I've had personal experience recently, which has been absolutely critical. So there's a phase 3 trial that is fully recruited. It's called the N-acetylcysteine trial, NAC, abbreviation NAC. NAC is the name of the supplement, the medicine that's being taken by mouth. The ambition is that that will slow progression over time. And we were going to be, Moorfields was going to be a site in the UK. We had tremendous difficulties getting the MHRA, the regulator, to review the study. It was locked in, sort of glacially suspended in animation for months and months and months. It took a lot of persuasion of the US sponsor to say, don't give up on us, don't give up on us. We've got lots of patients who are really keen to take part. And it was only with Retina UK intervening, contacting the lead of the MHRA, that suddenly things got unblocked. It was temporarily related. They reached out, suddenly our project was being reviewed, and it got reviewed really very rapidly. And I'm very proud that actually the UK is the #1 recruiter to that global study. It's the biggest trial for RP that's ever been done. There are 450 patients in it, and we are the biggest recruiter despite the last starting to recruit to that. And there'll be a readout from that in 1 year and then at 2 years. In terms of treatment development, I am very excited about lots of the therapies that are in human trial currently. There are many in late stage development, so phase 3, as I alluded to, for N-acetylcysteine. There are other drugs, such as those being developed by Belite Bio and Alkeus. Those are for Stargardt disease, the slow progression. One of those companies is in discussion with regulators, including the FDA, as John mentioned earlier. Other therapies that are genetic, that are also at the same stage, that I'm very excited about, the company's called Nanoscope. That's not a gene-specific therapy. You just need to have RP or Stargardt, they're trying it into both of these two conditions, advanced retinal failure, But this is a genetic technology, again delivered by these inactivated viruses, that tries to make what remaining retina is present light sensitive. So when you've lost your cone and rod cells, the light sensitive layer, it tries to make the residual retina light sensitive, optogenetics. So I'm optimistic about optogenetics. And there are other companies, including Restore Vision, that are out of Japan, and Ray Therapeutics out of the US, that arguably have more up-to-date technology they're trying to put in the retina. And I've seen some data from Restore Vision, and that looks incredibly promising, given they were actually treating patients who had no perception of light. There are equally promising earlier stage developments. In the genetic therapies, there are multiple companies either using 2 vectors to deliver a massive gene, or different technologies to correct the genetic fault. Those include Splice Bio and Avant-Garde Sepal Bio, Ascidian. They're targeting conditions such as Stargardt disease, USH2A, which is the commonest cause of recessive RP, and Usher syndrome. They're also targeting CEP290, which is a cause of LCA, and others. And then secondly, in addition, further drug therapies that are bespoke, which again I'm very excited about because of that bespoke targeted nature, such as those being developed by Octant for dominant RP caused by rhodopsin, the first gene that was identified. So I'm very, very optimistic about the future. I used to talk about being cautiously optimistic. I've dropped the cautiously, I'm just optimistic, which takes me very, very briefly, I know I was trying to catch up time, but I haven't at all, is AIPL1, which I've mentioned many times, and it's worth mentioning many times because it is not a marvel, it's miraculous. Genuinely, it's hard to believe. This is one of the most severe forms of Leber congenital amaurosis, so a childhood onset, actually from birth onset legal blindness. So far more severe than RP65. RP65 would be at the other end of the severity spectrum. AIPL1 would be at the most severe. So virtually all children are born only being able to perceive light. They only have light perception level of vision. And so they have very wobbly eyes, roving eye movements. And why did anyone look at AIPL1 given it's so severe? Because early during our understanding of genes, it was thought that AIPL1 was a very common cause of inherited retinal disease. But what actually transpired was that it's incredibly rare. Why was that? Because it's taken some time for us to become more efficient, knowledgeable how to interpret the changes we find with genetic testing. And a lot of the changes that were thought to cause disease in AIPL1 transpired to not cause disease. They were just normal variation, and disease was caused by other genes. So it left us with a very tiny proportion of patients. However, during that time where it was thought to be a very common cause, there was an animal model developed in Robin Alley's lab that had genetic therapy to replace the missing AIPL1 in that animal model, and the rescue was phenomenal, one of the best rescues that the laboratory has ever seen. And so at that point, allied with it's thought to be very common, and the rescue in the laboratory is fantastic, it was thought, well, let's find patients that could potentially be eligible for this type of therapy. Let's take it into the clinic. At that point, when we had realized that it was only very, very severely visually impaired children, the consensus was by seniors and mentors, which sort of take home, never believe everything you're told, was that these children are absolutely profoundly blind. They've got no retina from birth. There is nothing to treat. It's an entirely pointless endeavor, and you really should use resource for something else that's more likely to work. This all was coming around shortly after I got back, and I'd realized I'd found out that handheld OCT, remember handheld OCT? So handheld OCT, I said, well, how about we check? Because it's really hard to see the retina in an eye that's moving around at a great rate of knots to examine it on a microscope. You can't on a microscope, you can use other methods, but you can't really get any detail. With the handheld OCT, we established that there was a 4-year window of retina. So children are born with retina, but by 4 years of age, they have no retina. That central retina is gone. So in fact, there was retina that could be treated with gene therapy. We treated 4 children in one eye at Great Ormond Street. Every single child went from light perception to vision on a chart. Every single one. They all can see on a chart. And for most people on the chart, the big letter at the top, AOE, old-fashioned, 660. So they've gone from they can just tell if there's a bright light shining in their eyeball, to they can see the faces of their parents, their siblings, and start to play with their siblings. It improves their behavior in all aspects. Being profoundly visually impaired from birth impacts upon all areas of development. So that was transformational to those first 4 children. Given that improvement, we felt that, well, this is far better than we'd anticipated. What happens if we treat both eyes? Let's go on and treat both eyes. So we had another study of 7 children who had bilateral sequential treatments. All 7 of those went from either light perception or being able to see motion to dramatically improved vision on the chart. So we have 11 children who've gone from legally blind to not legally blind. And the first lot of children are now at 5 years follow-up, so it's still lasting 5 years. Will it last forever? Probably not. What lasts forever? Probably not. But 5 years of that level of improvement in vision, many people in the room will know that you can have a tremendous improvement in your function with maybe just a relatively small improvement in vision, will support their development at that critical time, and those benefits will last throughout their life. So we are in discussion with MHRA, FDA, EMA to get this approved. It's proving to be incredibly painful, which I understand in many ways. There needs to be those protections to make sure that we're not exposed to unsafe medicines. But we will get there. Timeline's probably 1 to 2 years. But I wanted to finish on that miracle. Thank you very much.